Good morning, everybody. My name is Adrienne McBride. I'm the Executive Director for the Fibrous Dysplasia Foundation, and we're coming to you live from Nemours Children's Hospital in Orlando, Florida. We're excited for today's session, and we'll be joined by Dr. Jason Malone, who will discuss the Fibrous Dysplasia McCune-Albright Syndrome Pediatric Orthopedic Care, and Dr. Robert Stanton will join us and discuss Fibrous Dysplasia, McCune-Albright system, and scoliosis. And he'll also give you expert advice about how to choose a surgeon. And as a not-for-profit, a 501c3 not-for-profit, Fibrous Dysplasia thinks it's important to bring educational programming to the Fibrous Dysplasia McCune-Albright community. And we thank you for joining us today. And I'm thrilled to be here with the experts. First, I'd like to introduce our speakers. I'll introduce Dr. Stanton, who's a little bit off camera right now. Dr. Stanton is an expert in general pediatric orthopedics, including fracture management, as well as the specialized areas of scoliosis management and benign and malignant musculoskeletal tumors. Since joining Nemours in 1987, Dr. Stanton has served as an attending orthopedic surgeon in the Nemours Alfred I. DuPont Hospital for Children in Wilmington, Delaware, and also as a surgeon-in-chief and chief pediatric orthopedics at Nemours Children's Specialty Care in Pensacola, Florida. Dr. Stanton is renowned for his work with the FD community, and he has graciously served his skills and insights with the FDF for over a decade, and we thank you for that. Right with me is Dr. Jason Malone. Dr. Malone is an orthopedic surgeon who joined the Division of Orthopedics at Nemours in August of 2017. He graduated from Midwestern University, Arizona College of Osteopathic Medicine. He completed a residency in orthopedic surgery at the Good Samaritan Regional Medical Center in Corvallis, is that how you say it, Oregon. And he completed his training with a fellowship in pediatric orthopedics at the Phoenix Children's Hospital. And he works closely with Dr. Stanton, so we're very privileged to have these two experts with us today. And most important, we'd love to hear from you during this presentation. So if you have a question for our speakers, please feel free to add a comment to this live stream or email us info@fibrousdysplasia.org. We'll be taking your questions today. We might not be getting to all the questions, but we'll save them for other educational opportunities in the future. And we will be answering the questions at the end of the presentation. You can also, and I know I'm going fast because we have limited time here, you can also use the social sharing icons at the right top of your player to post this webinar directly to Twitter, to Facebook, or LinkedIn. So without any further ado, I'd like to introduce Dr. Malone.
Thank you very much. Like she said, I'm going to be speaking about surgical challenges in fibrous dysplasia. Fibrous dysplasia can be broken up into two main categories for patients. They can be asymptomatically found, or they can cause symptoms in patients. Most of the asymptomatic fibrous dysplasia is found in one bone or monostotic bones. They're usually non-weight-bearing bones. They cause little deformity, and most of this is just treated by observation and excision if it's in an accessible area and if it's causing problems. But unfortunately, a lot of fibrous dysplasia can be symptomatic and cause great deformity. They can be found in any bone in the body. You can see the humerus and the tibia here. And the symptomatic bones are usually polyostotic bone, or involving multiple bones. They seem to be more aggressive in children. It seems to be worse around weight-bearing bones, around the hip, the pelvis. What happens is the cortex becomes weak, microfractures develop, and you get deformities. Symptoms these patients feel are as bone pain. They can sustain a pathologic fracture or a broken bone through the abnormal bone, and we can get deformities. One of the deformities that is very hard for us to treat as pediatric orthopedic surgeons is what's called the shepherd's crook deformity. That's where the proximal femur goes into varus or turns towards the body and becomes very difficult to reconstruct. But you can also see the tibia and other bones can deform quite a bit too, causing ambulation difficulties and pain. So our treatment goals as pediatric orthopedic surgeons are to treat pain. We want to try to prevent fractures, prevent deformities, and correct any deformities that do develop. For doctors, we want to go off guidelines, kind of following our paths of doctors ahead of us. The best way to follow those paths are following double-blind randomized studies. That's kind of the gold standards for how we do medicine. A randomized study is where you take two groups of patients, treat one way, treat one another way, and see what the outcomes are. But unfortunately, that's not done too much in fibrous dysplasia or McCune-Albright's. The problem is we have very limited research in it. The disease is rare. A lot of our research is expert opinion or retrospective studies, which means we look back at our charts of what we did. There are no standardized treatments, though we're working towards standardized treatments. A lot of the studies are done in adults or in monostotic disease, meaning being on only one bone. And a lot of these studies are studies mixed with other benign bone diseases or lesions. So our research is not the best, but we're working towards that to get better research. So kind of the meat and potatoes of my talk, we're going to talk about the surgical challenges. For being a pediatric orthopedic surgeon, we're dealing with children. Children have a different anatomy than adults. What do we do with this pathologic bone? Do we put new bone into the area? What kind of devices do we use to stabilize the bone? And how do we prevent future deformities from developing? So again, with children, we have small bones, so a lot of the equipment that we use for adults do not fit children. We have open physes or open growth plates, and that limits the way that we can treat patients. And children grow, so what works today may not work tomorrow because the child has grown and the bone is no longer protected. Again, just showing other pictures of ways that we can fix children's bones. We'll get into this a little bit later. And again, with children growing, this is a plate that was in a child's bone. The child has grown over the plates, now it's engulfed in the bone. So that causes other problems when we talk about growing children. Not only are we not protecting the bone, now we have something stuck in their bone. So what do we do with the pathologic bone? It is possible to resect pathologic bone if it's monostotic in a small area that is resectable. Unfortunately, when we replace this bone wants to turn back into fibrous plastic bone. So not always possible, and especially with polyostotic disease, such as these patients here, there is no way to remove this abnormal bone. The child will be left with no bone at all. And do we use bone graft? What are we going to use if we do remove the bone? Again, fibrous dysplasia wants to turn back into fibrous dysplasia. So this can be done in monostotic lesions. It should be done prior to any fractures or deformities, and unfortunately a lot of this does not work too well in children. When we talk about bone graft, now our ideal bone graft as an orthopedic surgeon, we want something that's strong, something that's osteoconductive, which means it acts as a scaffold for our bone, inductive, which means it stimulates bone to heal, and it gets replaced by healthy normal bone. But again, in fibrous dysplasia, that's not always possible. One of the first bone grafts, these are all the bone grafts that we have are available to us as orthopedic surgeons. We have autograft, which means comes from your own body. It can be both the inside of the bone or the outside bone, being the cortical cancellous bone. It can be demineralized bone matrix, which is really processed bone, or it can be bone substitutes such as calcium or coral. One of the first types of bone grafts that we used, and one of the most common that we use in orthopedics, is autograft, which means your own bone, and it's cancellous bone. This is the spongy bone inside your bone that we use. What's great, it's your own bone, so you don't have a risk of getting an infection. It does stimulate bone to heal and works as scaffolding. So this works really well in your average patient, but does not work too well in fibrous dysplasia. This does turn into fibrous plastic bone. So there are multiple studies showing very poor outcomes with using this type of graft, starting back from 1962, where they had pretty much 50% of patients had poor outcomes. In 1984, 25% of patients had poor outcomes. In 1987, their group, they had 81% of patients had poor outcomes with this type of graft. So it's really not recommended that we use this type of graft in children with fibrous dysplasia. Newer study, 1998, 100% resorption. With only the group in 2003, they had 5 patients, and they showed 3% having poor outcomes. But really, this is not a good graft, especially in children. It just wants to turn back into fibrous dysplasia. The other graft that actually was quite popular is the cortical graft. Again, this is the thick part of the bone that we use. What's nice about this, it's structural, it's strong. But again, this wants to turn back into fibrous dysplasia because it is the patient's own bone. It gets reabsorbed quite quickly. It became famous from Dr. Inking and his group, where they treated 15 patients, and they really reported poor outcomes in 2 patients out of their 15. So they thought it was a very good graft. But if you look in their research a little bit deeper, none of the patients had changes in their lesion size. Even though they reported good outcomes, the lesions were still there. So you can still see the fibrous dysplasia around the graft they put in. And all the patients were over 18 years old. So really, we're getting a mixed bag of bones. We're trying to compare that study for children. Other studies in 2008, they used a fibula, so the smaller bone in your leg. They put 8 of those into patients, and they had pretty much recurrence and resolution of and only partial resolution of the fibrous dysplasia as well. So they did not say in their study whether they was used in Marcune Albright or fibrous dysplasia, but really they also did not have the greatest results with only 8 patients. Other studies too, recently for 2015, 8 patients again. They reported no poor outcomes, but the average age was 40, if you see there. All this monostotic disease, and if you can see, they only followed these people up for 6 years. The graft is resolving, and it is the fibrous dysplasia is still there. So even though the patient had good results, the long-term studies don't really support using your own bone. A better graft that we do sometimes use is allograft. This is again someone else's bone, and using the cortex, the thicker bone, we think this is slightly better because it doesn't incorporate into your own bone or become fibrous dysplasia as quickly as your own bone does. So here's just one study where they did show with the monostotic disease in adults, where about 6 years later, the bone looked better. Still not perfect, but looked better. So this is the group here in 2017. They presented 28 patients, a mixture, again, a mixed bag of patients. Some of them had monostotic disease, one bone. 11 of them had multiple bones involved. One had McCune Albright. The ages, again, are all over the place. The average age was 23, but we had 5-year-olds compared to 50-year-olds. That's not the same thing. The mean survival time was 13 years, but again, 46, almost 50% of the patients had reabsorption, had reoperation for this. 31% had fractures, and 8% had continued deformity. So when they show more of this stuff, you can see some of the graft is completely resolved, about 50%. So even though this is the best graft we have currently, it still can only be used in certain areas and still seems to dissolve after time. Recently, Leet and their group in 2016 showed 25 patients, and they followed these patients 14 years, and they estimated that 50% of the time the graft is dissolved or reabsorbed and turned back into fibrous dysplasia. They compared all the graft types, because they, again, small patient population. They compared all the graft types and saw really no advantage of one over the other. And this is the NIH group helped with this study. They saw more reabsorption in younger children, so under 9 years old, which makes more sense. They have a lot more growth ahead of them. So if there's more growth, there's more chance that fibrous dysplasia is going to come back. So again, in summary, recent studies show that 50% of all bone grafts will reabsorb in fibrous dysplasia. The follow-ups on these studies are pretty short, 6 years. For 8 patients, that's not a lot of follow-up time. Most of these studies were done in adults. So if you are going to use a bone graft, the current recommendation is using an allograft in adults, monostotic disease, which means very small disease, one bone involved, and in a contained area. There are possibly in the future better grafts that are being developed, synthetic grafts. This is a picture of a synthetic graft being placed, and a plate can be drilled into it to kind of support it, but you can kind of see when that gets reabsorbed. So as of now, we don't have the greatest grafts, but there might be some in the future. So we talked about the problems that can happen. Now we're trying to figure out the ways to fix bones. So for orthopedic surgeons, we have 2 ways of fixing bones, either placing a device inside the bone or outside the bone. One of the earliest ways we fix bones were what's called non-locking plates. The way that these plates work, you have a screw, it just has friction against the bone and the plates, and that actually holds the whole construct together. But in poor quality bone, the plate can rip out like this plate is, and it also does not protect the entire bone. You can see there's a deformity going around this plate. So those are not that great to use, and actually pretty terrible to use in fibrous dysplasia. A stronger construct is a fixed angle device, where you actually have one part of the plate, this is the blade plate, is fixed, so it actually is stronger. It doesn't actually pull out of the bone. The only way to actually pull out of the bone is pull it directly straight out. But again, these do not protect further down in the bone. You can see here there's a fracture in a patient with fibrous dysplasia right below the plate. Another way that surgeons have tried are external fixators. This is a hexapod frame, which means 6 legs. You can fix a bone in multiple planes, but these are poor in fibrous dysplasia. What happens is you put these pins through the skin into the bone. These pin sites have a tendency to refracture through. Once you take this frame off, the bone is not protected. So now you have more fractures again too. So these work for other deformities, but pretty poor in fibrous dysplasia. A better choice that has recently come out in the 2000s is what we call locking plates. The way that these work actually is slightly different from a normal plate. There is a thread on the screw itself and in the plate. So when you put the screw into the plate, it actually almost cold welds itself to the plate. So you get a fixed angle device like the blade plate that can protect parts of the bone. We routinely use this in the proximal femur to protect the neck, but again, it doesn't protect the entire shaft. We do like to use intermedullary devices if possible. Something goes up the canal. What that allows is strength for the bone. It strengthens bone by using the device and the bone itself to reinforce the strength. Hard parts for us is that the canals are very small in children, and that sometimes with fibrous dysplasia, the canal actually is not even there. So these are two devices that we had used in the past. Newer devices, such as this, the locking nail, have been created for children. So they're smaller. They do have a way to protect the neck. But the problem again is these patients are growing. This is no longer protected down here if you have fibrous dysplasia down there, and it could fracture later on in that area. Also, we don't like to use these in patients under about 8 or 10 years old. The blood supply to the femoral head up in the hip is right in the area you put this nail in. So we could also disrupt the blood supply if it's used too soon. But there are other devices, again, that came out for other diseases such as osteogenesis imperfecta. This is a phosphate wall rod. Again, it is a rod that goes down the nail. It is more skinny. It can be used in smaller children. But again, there's no way to protect the femoral neck if you need to besides K-wires, which aren't that strong. So there are other ways that we can protect it, but there's no great way at this moment. They are developing new ways that are getting better and better. This is a device that actually uses a locking plate that locks into the nail. So you get kind of the best in both worlds where the locking plate protects the femoral neck, but you have the nail protecting the shaft. But this is not non-growing nails. So again, you don't protect the further down. And these nails are quite skinny, if you can see, which is great for kids. But again, because they're skinny, they can break because they're not as strong as a thicker nail. So we're coming up with newer ways to fix children's bones, but nothing is perfect yet. So what challenges can we pass along to our surgeons who don't do a lot of fibrous dysplasia? One thing that I want to pass along is one of the challenges that I noticed when I started working with Dr. Stanton is there's a great deal of blood loss with these surgeries. Fibrous dysplasia, it can be very vascular, so surgeons who are not prepared should be prepared. There are always the risk of needing blood transfusions. Here and other hospitals, we have what's called a cell saver. It's a suction that we use during surgery where we can actually recycle the patient's blood, give them a transfusion of their own blood if they lose too much blood. And we stage surgeries here as well. So we'll only do one bone if it looks terrible, or one whole limb, but we won't fix all 4 parts of the bone because it's just too much surgery, too much bleeding. Other thing to be aware about too is, as I was saying earlier, sometimes children do not have the canal that you can put a rod down. That is not always apparent on x-rays. It looks like there's a canal. Normal orthopedic surgeons who don't deal with fibrous dysplasia might think they have a canal. They're used to putting in rods, but they get in there and they can't get the rod down. So there are techniques of making osteotomy and making your own canal, but surgeons should be aware that that is a possibility, and families should be aware to tell their surgeon that you're going to have a surgery, that there may not be a canal to put the rod down that they're trying to put down. And finally, so some of our recommendations for treatments, we want to prevent deformities from happening. And when they do happen, we want to fix them. If we can fix them with an intramedullary nail, that's what we want. Those are the strongest constructs we have. We can do them both in the femur and the tibia. But sometimes, again, kids are too young for that. So at times, we will use a locking plate for younger children. It does not protect the shaft, but it can protect the neck. And once they're big enough, strong enough, more space, we can exchange that for a nail if a new deformity happens, new problems happen. So that's our kind of going treatment for right now is fix the younger kids with the plates and the older kids with the nails once they're able to have it done. So for summary, fibrous, we were talking about this earlier today with the families, fibrous dysplasia kids are more active, they run around, they play, they get more deformities, more fractures. This causes pain in children. This seems to get a little better as they become adults because they learn their bodies, they actually are less active and can tell when they're having fractures and kind of lay off the activities. Bone graft does not work well, if at all, in polyostotic disease, and especially in children less than 9 years old. Use an intramedullary device when possible that protects the whole femur. It does stronger and limit the number of surgeries as you can, if possible. Good medical management with a good endocrinologist, a good team can help out. And if the patient's having pain but no deformity, activity restrictions is still a good non-operative treatment that can get kids back to feeling better and back to activities without having to operate. So I want to thank Dr. Stanton. He got me involved in the Fibrous Dysplasia Society. This is us in Edinburgh this year, and he's eating haggis for the first time. So I wanted to get a picture of that. I thought it was awesome. And Dr. Collins from NIH. And I want to thank our hospital here in Nemours for letting us host this webinar. So I have the pleasure now of introducing Dr. Stanton. He is my senior partner here at Nemours. He got me involved in the Fibrous Dysplasia Society, and he's going to give a talk on, are you doing, which one first?
I think scoliosis or surgery, how to choose a surgeon.
Okay.
Get them both.
Okay.
We'll pull up the surgeon one. We want first. So here's the mic. Oh, I'm dropping. Do you want the phone? I'll pull it up over. It's over here. Oh, we did it. There you go, sir.
All right, this is a little bit new for me. I'm used to speaking to people that are physically present, and there are some folks that are here, but we have people online, and that's kind of new for me. Hopefully, I won't mess this up. People have continually asked me via email and in person, you know, how do I pick a surgeon? How do I know that the person I'm talking to is the right person to help my child? And of course, this does also apply to adults too. I think I'm less helpful when they ask me how to find an adult surgeon, because I really don't know that much about the persons that understand fibrous dysplasia in the adult orthopedic world. I think you have choices. Most of the time, I think your best bet is a pediatric orthopedic surgeon. The pediatric orthopedic surgeon not only understands orthopedics, but understands children. And that's a problem if you go with an adult tumor surgeon. And adult tumor surgeons understand how to take tumors out, but they're not really good at dealing with the deformities that fibrous dysplasia causes. And we know from what Dr. Malone has just told you, and my experience as well, you can't remove these tumors completely in almost every case unless it's a very, very localized monostotic disease. And that's not generally what we're talking about with our patients. Polyostotic disease is so widespread that it's unrealistic to expect that you can remove that disease. Whoop, okay, going the wrong way. This button's very sensitive. So the general orthopedic surgeons in the community are dealing mostly with trauma reconstruction, and of course sports medicine. They, in my opinion, would be a pretty poor choice for your disease. Many of the pediatric orthopedic surgeons are associated with university treatment centers, children's hospitals like the Nemours Children's Hospital where I'm standing now, or through the Shriners Hospital system. And the Shriners Hospital system is an expansive system that encompasses just about every part of the United States. And there are many, many pediatric orthopedic surgeons working for the Shriners system. They are universally excellent and experienced people. In the Shriners system itself, they have an 18-year cutoff. That's a hard cutoff. But many of these surgeons also have dual appointments at university treatment centers across the street, next door, you know, down the street from the Shriners facility. So some of them that you may seek treatment from when your child is small can occasionally take care of your child when your child's not a child anymore at 20, 22 years old. They just go down the street to the university hospital. So in some cases where it's a difficult transition from childhood to adult care, surgeons that are associated with the Shriners system may be a very good choice. So, all right. When you're interviewing or talking to a surgeon, and I say interview because I think it is important on the first visit to consider that an interview. You're asking for advice, you're listening to the answers, and you have to make that ultimate decision. Is this person the one that you want to take care of your child? What questions should you ask? Well, you want to know if they have heard of and have treated patients with this disease. Do they have patients that they've treated in the past? I think that it is difficult for a surgeon to look you in the eye and say, no, I've never treated anybody with this condition. But you don't get to be an expert in this condition overnight. And I know a lot about this from learning what not to do, right? And I learned the hard way with the first few patients that I treated. I learned about bone grafting and the fact that it doesn't work, but I did it when I was very young and inexperienced. So somebody has to learn, and that's what Dr. Malone is working with me, so he will not have to make the mistakes that I made as a young surgeon, learning what does not work. How many surgeries have you done? What kinds of disease deformities have you treated? And then this is important too. I think when a surgeon has treated people with McCune-Albright syndrome specifically, they will absorb information about the other aspects of the disease. Why is this important? Well, when your child has a pathologic fracture, it's a semi-emergency, it's urgent, you have to get treatment. But I think it's important to understand that the other aspects of this condition can be a lot more medically important to the child than the broken bone. If your surgeon doesn't understand the other aspects, especially the metabolic bone disease and endocrinological problems, then you can focus only on the bone, only on the physical aspects of the deformity or the fracture, and miss out on the other treatments that are very important for the overall health of the child. Can your surgeon discuss metabolic bone disease? Can they discuss advanced bone age from precocious puberty and the treatments that are necessary for that? Do they understand that even though the legs are crooked, involvement of the skull is also very important and may not be apparent? Do they understand that hearing and vision are important things to be watched and monitored, especially in the McCune-Albright syndrome? Chronic pain issues. Most surgeons are not particularly interested in helping you with chronic pain issues, okay? But they should have available to them experts in pain management that can help with the management of the pain that many patients with this condition manifest. This is important too. What other tests do you think my child needs? Okay, and there are some answers that sometimes will alert you to the fact that that surgeon maybe doesn't know much about the disease, okay? What about a bone scan? A bone scan is an injection of a radioactive tracer material called technetium-99, and you wait a few hours, and then it goes into the bone wherever there is extremely rapid bone turnover, and it will show you, in general, every spot in the skeleton that the patient has active disease. It will also show you wherever the bones are growing, so the normal growth plates around the knees, for instance, which you can see in this scan, those will light up, and that's normal. It's a child, there's a growing skeleton, and there's great turnover at the growth plates or the physes. But wherever there's abnormal intake, like the pelvis, the femur, and the humerus in this particular patient, there is disease. Where we don't see is very much disease in the skull. See, now the bone scan is very helpful for determining where in the body the disease exists, and also the people at the National Institutes of Health have developed a grading system for total body disease burden based on the bone scan. We also know, though, that the bone scan is not particularly helpful in extremely young children, 2, 3 years old. If done around age 5, you will detect every spot in the skeleton that will ultimately be involved. New areas don't appear. They just can be so small at age 2 that they won't be picked up by the typical bone scan. They're there, maybe 2, 3, 4 cells, but not enough cellular disease to pick up and show up on a bone scan. By age 5, however, the NIH studies have shown that all disease areas will be visible. Okay? So then what about CT scans? Well, if your bone scan doesn't show any uptake in the skull, then you don't need a CT scan. If you have uptake in the skull, then you would need a baseline CT scan of the skull. But what about a CT scan of your femur? If the plain x-ray shows you have femoral involvement, you don't need a CT scan of the femur for anything. All right? It might be a very intriguing and interesting test to look at, but it doesn't help treat the patient. if your doctor is enthusiastic about ordering a CT scan of your child's extremities, they probably don't understand the disease, and there is a significant amount of radiation associated with CT scans, so they should only be done when absolutely required. What about a biopsy? If your doctor says, oh, we need a biopsy to prove what your kid has, well, that again, you should be suspicious, okay? Biopsy is rarely indicated. Occasionally, monostotic, single bone disease of fibrous dysplasia can look atypical. It's not the picture you would pick to put in your textbook chapter on fibrous dysplasia. And occasionally in monostotic disease, you might want a biopsy. In polyostotic disease, the involvement of the bone is extremely characteristic, and experienced radiologists and experienced orthopedic surgeons should have no trouble telling you definitively your child has fibrous dysplasia. You do not need a biopsy. So if they're recommending a biopsy, that's a clue that you're dealing with someone that may not know this disease very well. So the CT scans, as I mentioned, are usually quite appropriate, at least for initially analyzing the amount of involvement in the skull, and occasionally down the road, follow-up CT scans may be necessary to monitor the expansion and proliferation of the fibrous dysplasia in the skull. It is rarely, if ever, helpful in managing extremities. If a patient has a severely deformed femur for which a very complex reconstruction is indicated, occasionally the surgeon may want a CT scan for the purpose of developing a 3D model of the upper femur to gauge how to make the cuts to reconstruct the upper femur. So that might be a small exception to what I've just said, okay? We are going to talk about scoliosis in a few minutes in a separate talk, and usually before I operate on scoliosis in the spine, I will recommend a CT scan. So I know exactly where the fibrous dysplasia is in the spine and where it isn't, and that will help me to determine where to put the fixation devices that I'm going to use for scoliosis surgery, and we're going to talk about that in a separate lecture. All right. There is, as I mentioned, radiation exposure from CT scans, so I try to limit my use of CT scans. All right, MRI, magnetic resonance imaging. The MRI is an amazing device. I'm old enough to practice for many years before it was even invented. Like all new devices, when it comes on the market, people use it for everything before they figure out what it's good for, what it's not so good for, okay? The MRI makes wonderful, gorgeous pictures of the anatomy of your body. It relies on magnetizing water molecules, and then the pictures are generated in a way that I can't even understand. But tissue that has more water in it makes beautiful pictures. Tissue that has very little water content is black. Well, guess what? Bones are pretty dry. So bone is black, okay? And soft bone and hard bone, they're still black. So black is black. Sounds like a line from AC/DC. I don't think MRI is very good at all at imaging bone. So if you really want to see the bone, if you have to see it, a CT scan is better than MRI, okay? Small children have to hold really still. When you get an MRI, if they move, it messes everything up. So it causes artifact. You have to give them deep sedation, and in really small kids, general anesthesia for them to hold still long enough to get an MRI. Another reason why MRI is almost never really helpful in this condition, okay? For those of you who have heard my talks in the past know that there is a condition called aneurysmal bone cyst. that can occur in pre-existing fibrous dysplasia tissue, where the fibrous dysplasia, which is bad enough, then segments of it can degenerate into an aneurysmal bone cyst where there's a lot of blood and very little tissue, and the cysts can expand. They're fairly common in the skull, but they can be seen in many other places in the body where fibrous dysplasia used to exist. And they are expansile, and they're very hard to tell the difference between just bad fibrous dysplasia and an aneurysmal bone cyst. And an MRI is very helpful there. Okay, so if you're suspicious that a patient who's poking along doing pretty well for a long time, and then over the last 6 weeks is having an awful lot of increasing pain, you take an x-ray, fibrous dysplasia looks maybe a little worse than it used to. If you think it's aneurysmal bone cyst developing, you'll need an MRI to find that out. Okay, so the last question is that you ask your surgeon, all right, what are you recommending at this time? Okay, how often do you need to see my child? Well, what's the typical answer there is if it's a 3-year-old, I need to see you every 4 to 6 months. If it's an 11 or 12-year-old, I may only need to see you once a year. It all depends. You know, the children that are 3 and 4, things can change so fast that if they say, come back in 9 or 10 months or come back in a year, that's probably not often enough. Things can go bad so fast in this condition. What tests are you getting at the next visit? Generally speaking, plain ordinary x-rays are good enough to tell what's going on. You don't need fancy expensive tests, plain x-rays. So, surgery doesn't cure fibrous dysplasia, we know that. It is often helpful in managing the disease deformities. It can be helpful in chronic bone pain, but in general, I've learned from my colleagues at the NIH that good metabolic care of the bone health with endocrinology support is very, very helpful at curing or at least ameliorating chronic bone pain. In years past, I used to put a lot of intramedullary rods into bones that weren't crooked. They just hurt all the time with weight bearing, and the rods helped cure weight bearing bone pain. But that is not occurring very much anymore, as the endocrinology people have understood a lot more about how best to treat the metabolic bone disease aspect of fibrous dysplasia. Chronic bone pain almost never requires surgical intervention. Okay? Occasionally, but not as often as it used to. Genetic and basic science research is the key to this disease. So I will make another statement, and that is that trying to convince your surgeon to cooperate with research, especially at the NIH, is important. When we do these reconstructive operations, we're making cuts and taking out wedges and rearranging the anatomy. We often have leftover bone. We have wedges, we have chunks of bone that have been excised in order to change the angles. And that bone, you can send it to your pathology lab, they'll make slides out of it and throw the rest away. Or you can send it to the NIH and they will do research with your child's bone, which can help people down the line. Next generation coming with this disease may get better treatments based on basic science research. So if you talk to Allison Boyce or Mike Collins at the NIH, they'll send you all of the stuff that you need to package up the bone specimens and send them to the NIH for basic science research. They'll coordinate permits with the parents. They take care of all that for you. It's very painless. You just have to think about it ahead of time and mention it to your surgeon. Would you be willing to send excess bone to the NIH for research? So I'll make a plea that you consider that. All right, I think there's a balance between early surgery and late surgery. We know that, especially in the upper femur, regaining any semblance of normal anatomy can be very difficult when the deformity is allowed to become quite severe. When you get a really bad shepherd's crook deformity of the upper femur, reconstructing that to resemble anything close to normal anatomy can be quite difficult. So I think, although I tend to be, in most cases, fairly conservative, for the upper femur, I tend to be pretty aggressive about recommending fairly early surgery before things get real bad. All right. The patients and families that have endured my attempts to treat them over the years have taught me a lot about what does not work. And I'm trying to pass along that information so people don't have to go through that again. The MAGIC Foundation has been very, very supportive and helpful over the years. And so, of course, has the Fibrous Dysplasia Foundation, which is helping and sponsoring today's talks, okay? The Nemours Foundation has been very good about letting me travel, and my partners have taken care of my patients when I'm not here to take care of them. They've been very helpful in supporting my career and my interest in this condition. I think my email address is available. I know it's on the MAGIC website, and it probably is on the Fibrous Dysplasia website. I'm always available to receive email questions about cases, and if you send me x-rays via email, I'll look at those and try my best to tell you what I think would be the best course of action, and you can feel free to share that with your surgeons. Any surgeons that want to come and talk to me and call me, I'm willing to discuss treatment options and give advice whenever possible, okay? Right. We will have a space for questions after my next talk.
Yes.
All right, so trying to get the next talk up. Scoliosis is curvature of the spine. It's we treat lots of children with scoliosis at this hospital, most of whom don't have fibrous dysplasia or McCune-Albright syndrome. I think that over the years, people at the NIH have discovered that scoliosis is not that rare in fibrous dysplasia, and perhaps over time has been underappreciated as an important aspect of the child's care. And there are some reasons for that. When your child has a fractured femur, people are concentrating on taking care of that, figuring out how to deal with that deformity or fracture, and they may not be paying that much attention to the spine. But I think it's important to understand how frequent scoliosis is in this condition. So a while back, the NIH did a study, and this talk is based on that information. I should have said this before on my first talk. I don't have any financial conflicts of interest. What does that mean? It means I don't have any stock in any companies that make stainless steel or titanium implants to put into the patients. And I'm not recommending any off-label use today. What that means is I'm not recommending you put instruments into a tibia that were designed for a femur. That would be an off-label use. So this is a disclosure slide. And then the Nemours Children's Hospital is not responsible for the opinions that I'm giving you guys today. Just me. Just me. All right, so polyostotic fibrous dysplasia, as we know, has a wide range of clinical severity. I have some children who come to me at age 11 with a newly diagnosed case of fibrous dysplasia. Well, I know that patient doesn't have severe disease if they got to be age 11 before someone figured out that they weren't perfectly normal. But we also have kids that are 15 months of age and they already have at least one fracture or deformity. The disease proliferates during childhood, we know that, and because the skeleton is growing, they have frequent fractures and bone pain and extremity deformity, all of which is usually quite obvious, especially in the McCune-Albright variant of fibrous dysplasia. The deformities can be quite obvious, and it causes your eye to go directly to there. And we also know that the endocrine involvement has to be appreciated, but is silent. But scoliosis can often be silent as well. It's often not appreciated if the whole patient is not examined carefully. And you know, it should be obvious that you can't examine the patient if they have all their clothes on. You need to undress the patients and you need to look at them top to bottom, because this is a disease entity that involves the whole body. Now, just because they don't have scoliosis when they're 5 or 6 doesn't mean they're not going to get it later. So in early cases, it may not even be physically detectable, and it certainly is asymptomatic. So you have to recognize that we need to look for it. If you're treating a 5 or 6-year-old kid, as they start to get 6, 7, 8, 9, you need to be on the lookout for scoliosis. Okay. So here's one of our patients from 2013, and we were looking for scoliosis, and we took an X-ray, and there isn't any. Okay, it looks really nice. There might be a slight little bend to the spine. Anything less than 10 degrees of curve is considered normal. This is a normal X-ray. So unfortunately, this patient who does not live in the United States was followed at another location, and in 2019, now the patient's got a problem. Okay? So this is a surgical grade curvature of the spine that will require surgical intervention. There's very little information available on treating scoliosis non-surgically. What does that mean? Braces. If you may have heard that scoliosis patients who have mild curves can be managed with braces that compress the thorax. They hold the spine in a better corrected position for a few hours a day, and that over time we may be able to stop the curve from getting worse and avoid surgery. And there's no articles ever been published on using braces for scoliosis in fibrous dysplasia patients. We don't know if that will work, but if you don't take an X-ray and you don't detect the curve early enough, you don't even get a chance to try it. Okay. Right. So serial radiographs over time to determine how much curve is present and whether it's getting worse over time. That's important. In the study that we put together using the NIH patients, which I'll talk about in a minute, we just arbitrarily have decided to grade scoliosis as mild from 10 to 30 degrees, moderate 30 to 45 degrees, and severe 45 degrees or more. Now why is that severe? Well, because generally that's when we start to recommend surgical intervention. Okay. So the individuals at the NIH put together a research project that I was part of, a small part of, where they looked at a subset of the ongoing clinical study that they have had for many years at the NIH for patients with polyostotic fibrous dysplasia and McEwen-Albright syndrome. This was published in the Journal of Bone and Mineral Research, and Allison Boyce was a significant and I would say primary author of the study. 138 patients were evaluated, and 61% had scoliosis. That would be 84 patients. Okay. So over half of the patients had curvature of the spine. Not all of them were bad. 55 were mild. So of the people who had scoliosis, over half of them were mild, 10 to 30 degrees. They required no actual intervention, just to be monitored. 13% were moderate. Those would be people that we would consider trying to brace if we get them young enough, right? 22% or 18 patients had severe curves over 45 degrees. Those would all be surgical candidates, okay? Now, they didn't all get surgery. Only 12 had surgery, and detailed follow-up information for purposes of this published study was only available on 10 of those 12, so 2 patients were lost to follow-up. There was one instrument failure. What does that mean? It means instrumentation was used in the spine. An attempt to secure a spine fusion was made surgically. Didn't work. The instrumentation came loose. The patient had to have a revision operation. Spine surgery for scoliosis is done by placing instrumentation into the spine and then destroying the joints, excuse me, the joints in the spine, and adding bone graft to try to secure a solid arthrodesis or fusion of the spine in the best corrected position you're able to achieve. And that keeps it from getting worse. 9 of the patients had stable fusions. 2 untreated patients who never had surgery died as a result of restrictive lung disease. So untreated severe scoliosis can be lethal. Okay? Not trying to scare people, but I think it's important to know. All right? Scoliosis progression was associated with hypothyroidism, hypophosphatemia, leg length discrepancy, and total body disease burden, which I talked about, can be measured by that bone scan. Scoliosis progression is not affected with bisphosphonate treatment. Okay? All right? Okay.
So are there any questions from the room? Okay. Dr. Stanton, we've received some questions online and we're running out of time, so I'm just going to direct them to you.
Okay.
Can everybody hear me, I hope? We've had several hundred people watching these presentations, so we're really pleased about that. The first question that I have is, when should a young person establish a relationship with an orthosurgeon? We've gotten mixed messages about the timing of bone scans. What do you recommend?
Unless there's an outstanding reason for a bone scan before age 5, it's probably not a good idea. If you do it at age 3, you're going to have to redo it again at age 5, so it's probably not necessary unless there's some other explanation why a person would need a bone scan before age 5. Most of the patients who present either have precocious puberty as their presenting symptom, or a fracture. If they have a fracture, they're going to meet an orthopedic surgeon very early in life. If they have precocious puberty, your endocrinologist is going to be involved. They will discover that the patient has McCune Albright. They will identify the need for bone management, and they will usually tie you in with an orthopedic surgeon.
So this question is for the both of you. Will removing a bone entirely remove the FD pain? For instance, can I remove an FD rib and be pain-free from that lesion?
Yes. Yes.
That's an easy question.
Okay, well, basically, a rib can be sacrificed without any trouble. Okay, if the involvement is in one rib, that rib can be totally excised. It's an expendable bone, and that generally will be very effective. But one rib involvement isn't common. Most people have a whole bunch of ribs involved, and you can't take out 3 or 4 adjacent ribs. That will not work.
We've gotten several casting questions. What are your recommendations regarding casting? For example, after proximal femur corrective I'm not saying this correctly,
Osteotomy.
the locking plate. In case of casting, what type would you recommend and for how long?
Yeah, well, that's a hard one. When you put the plates into the patient, you're putting screws into their bone, and the surgeon will get a feel for how good or bad the bone might be. If the bone is very, very soft and you're afraid that your plates and screws are going to fail quickly, you might want to supplement that with a cast, but we try our best to avoid casting. And if we have to do casting, we try to do it for just a few weeks, and we try to get the patient standing, even in a cast, as soon as possible.
And as a final question, how long would you suggest casting for bilateral osteotomies with tibial rotting in both? Is this different for FD patients than the normal population? The person writes, my daughter had surgery Friday and they want to do 4 weeks full leg cast and 6 weeks below the knee.
I think 6 weeks is excessive. 4 weeks isn't unreasonable. 3 to 4 would be pretty good, but it depends on how bad the bone is.
And finally, I have a question. You mentioned that should all FD patients be seeing an endocrinologist, even if they don't have endocrine symptoms?
Anyone who has polyostotic fibrous dysplasia requires at least one initial evaluation with endocrinology to be absolutely certain that they do not have any abnormal endocrinology findings. If they've been studied, worked up, and everything is normal, then that patient doesn't have the McCune-Albright syndrome. They just have polyostotic fibrous dysplasia, and they're not going to get endocrinology problems later if they don't have them at the initial screening. But anyone who has more than one bone involved with FD should see an endocrinologist for that initial evaluation.
Well, I want to thank everybody for their questions. But before we conclude, I'd like to invite our board member, Leah Surprise. She's from the Fibrous Dysplasia Foundation, and she has a few words to say.
Sure, yeah. So, on behalf of the Fibrous Dysplasia Foundation, and we all know that it was founded by Charles Harles, who we just got word this morning passed away. Sorry. So it's with even greater respect that we're giving this to you. The Fibrous Dysplasia Constellation Award, which is right here for you, was created to honor those who made outstanding contributions in our effort to improve the lives of anyone living with fibrous dysplasia and McCune-Albright, which is you for sure. Dr. Stanton is widely recognized as a leading expert of orthopedic pediatric care and has continued to develop his practice to provide the best possible management for this disease in our children and our patients. He's always been very giving, sharing his expertise within the community freely, and beyond his care for patients and willingness to share his knowledge, he also collaborates with researchers at NIH, as well as the new doctor coming in. So undoubtedly, we know more today about FD care just because of Dr. Stanton. So we thank you very much, and I appreciate it, and thank you so much.
Thank you.
And it's, like I said, even more because of what happened this morning, so in memory of Charles.
Thank you.
Well, this is a very poignant time for everybody at the Fibrous Dysplasia Foundation, and I just want to thank Dr. Malone and Dr. Stanton for joining us today. And I just want to remind everybody that Fibrous Dysplasia Foundation is a 501c3 not-for-profit charity. We need your support, we need your help. We're going to be launching a very ambitious Giving Tuesday campaign so we can continue to bring educational opportunities to you through webinars and through other media. We realize that we haven't gotten to everybody's questions, but Dr. Stanton has been so gracious about sharing his email. I'm sure he'll get questions. And again, I want to thank everybody for being with us today, and I want to thank the folks at Nemours Children's Hospital for hosting this event. From the bottom of our hearts, thank you and have a wonderful day.